significant differences between the cases and control. We tried to do a principal component analysis to see if we could identify any significant changes, and from the PCA, these cells seem to be a bit different from this, but the bit plot doesn't seem to give us any clear significant differences between the two. We did correlation analysis to look at the relationship between the cells, and also a dendrograph to look at the classes of the cell populations. So this is an ongoing study, and then we still are recruiting patients. But from the data that we have, we are saying that no significant expression of peripheral T cells was observed in this cohort of colorectal cancer patients, and thus it confirms with literature which says that peripheral T cell expression is not very much perturbed in colorectal cancer cases. So from this study, we are hypothesizing that in colorectal cancer cases, immune response might be highly localized within the tumor microenvironment instead of the peripheral environment. And for that matter, trying to target, and so it would be interesting to rather study the cells themselves than trying to look at the peripheral environment of the tumors. And the tumor microenvironment, or the tumors might be creating an immunosuppressive environment, which is preventing or reducing the expression of the T cells. And T cells trafficking might be highly regulated, and many of the activated or dysfunctional T cells may be sequestered within the T cells. So further studies need to look at by exploring these hypotheses in order to help us properly appreciate and understand what exactly is going on within the tumor microenvironment. These are some of my references. Thank you very much.
Thank you very much, Jacob, for your presentation. We will want to take all the 6 presentations, then we line them up for the questions. Each presenter has 10 minutes to do his or her presentation. So if you have rehearsed for more than 10 minutes, try and summarize your presentation. Thank you, Jacob. I think you did it within time. Our next presenter is Monica Ahiado. Sorry, car numbers AS 231018 and AS 8288R. Your attention is needed outside. You've blocked someone. AS 231018 and AS 8288R. Thank you.
Good afternoon, everybody. Please, my name is Monica Ahiatome. I am presenting on the topic modulation of cytokines in response to anti-filarial treatment in onchocerca volvulus infected individuals. My presentation outline goes like this. It starts from introduction, spanning to acknowledgement. So some background of my study. Onchocercitis is a parasitic infection that is classified as a neglected tropical disease. It is caused by onchocerca volvulus, which can lead to skin and ocular pathologies as a result of the host's immune response to the microfilariae that is present in the female adult worms and release of antigens of the Wolbachia endobacteria that is present in the worms. This immune response to the parasite, as well as the products and the Wolbachia, can lead to T helper 1 and 2 immune profiles. These immune profiles can lead to the production of cytokine interleukins, antibody isotypes, as well as populations of eosinophils, basophils, mast cells, and macrophages. So the rationale and the justification of the study. Mostly, onchocercitis infection elicits type 2 immune response that is manifested by enhanced expression of cytokine interleukins such as IL-4, 5, 9, as well as IL-13 to the parasite as well as its antigens. Also, the Wolbachia present in the worm and its molecules can also activate immune cells through toll-like receptors to release type 1 cytokines, such as tumor necrosis factor alpha, IL-1 beta, IL-8, and 16. All those studies have shown inconsistent reports. It is known that infected individuals that harbors high microfilarial loads generally express high levels of IL-4, 5, and 13 cytokines. And these cytokines, in addition, recruit and activate other immune cells, such as basophils, eosinophils, and macrophages that are involved in delicate parasite host equilibrium and changes these immunological processes in the host. Studies have shown changes in cytokine levels in infected individuals after treatment with macrophylaricida drugs such as ivermectin and DEG. Recently, rifampicin, when combined with albendazole, has caught a lot of attention as a potential alternative anti-Wolbachia treatment for onchocerciasis. Cytokine modulation in rifampicin has been shown to alter favorably in diseases such as tuberculosis. However, this is not known in onchocerciasis infection, especially when the drug is administered at high dose. Therefore, there is a need to evaluate these effects in this domain. So what is the hypothesis of this study? We hypothesize that treatment with high-dose rifampicin, when combined with albendazole, will lead to a significant improvement in the prognosis of onchocerciasis infection by favorably regulating the levels of cytokines associated with this disease. The aim is to investigate the prognostic effect of some selected cytokines involving IL-1 alpha, 5, 10, 13, as well as interferon gamma, following onchocerciasis treatment with high-dose rifampicin combined with albendazole. So the method that we employ in this study, ethical approval for the study has been sought. The study was done in some endemic communities in Setu-Akotumra district in the Western North region of Ghana. The study was a retrospective cohort study where samples were obtained from a randomized phase 2 pilot trial in Ghana, titled Alternative Treatment Strategies Using Anti-Wolbachia Drugs to Accelerate Elimination of Onchocerciasis and Lymphatic Filariasis. So selection of the participants, as I have already said, the samples were drawn from a randomized clinical trial where 120 participants were allocated into 4 treatment arms. Arm 1 was given 35 milligram per kilogram per day rifampicin combined with 400 kilogram per day albendazole, and it was given for 7 days. Arm 2 was given the same regimen, but was administered for 14 days. And Arm 3 was given only albendazole and was administered for 14 days. Arm 3 was the control group, no administration of drug, but follow-up was done. So the sample processing and analysis that were employed in this study, the EDTA plasma samples that were already stored in -80 freezer were retrieved. They were thawed only once and aliquoted. And ELISA assays were done in the 5 analytes, that is IL-1 alpha, 5, 10, 13, and interferon gamma. The quantification of the analytes were done using R&D dual-set ELISA development systems. And the ELISA data was analyzed using softmax Pro 7.1. All statistical analysis of the data was done using GraphPad Prism as well as Theta. And the significance was pinned at p less than 0.05. Concentrations of all analytes were calculated using the respective cytokine standard. And all censored baseline data were removed from the analysis. All the samples that were below the limit of detection of the assay were set to 1 picogram per ml for calculation. So some interesting results from our study. This table depicts the study population characteristics. And from the table, we can see that gender and microfilarial load were not significant when compared to the 4 treatment arm. However, the age is significant. Maybe this could happen during the randomization process of the clinical trial. So this table depicts the number of samples within the limit of detection. As I have indicated, we analyzed 5 analytes, but from this table, we were able to it was only 3 analytes that were within the limit of detection of the assay that we employed. So this figure shows the changes of IL-5 levels in response to the treatment given to the participants. From this figure, we could realize that there is a generally decline in the IL-5 following treatment. However, we observe a significant difference when baseline was compared to 20 months in arm 1. So this figure shows the modulation or the changes in IL-10 levels in response to the treatment given to the participants. Unlike IL-5, we realize that there is a significant difference in all the treatment arms. Specifically, treatment arm 1 and 2 show significant difference when baseline is compared to 4 months as well as 20 months. In treatment arm 2 and 4, the significant difference was observed when baseline was compared to 20 months. Because of the irregularities in the level of cytokines of this IL-5 and 10, we decided to compute their ratio and do analysis. So after the analysis, we realized a general decline in all the treatment arms. And we observed that the arm 3, that is the albendazole alone arm, has a significant, was very significant when baseline is compared to 20 months. So some discussions and conclusions that we drew from this study. Despite the reported sensitivity of the assay that we have used, IL-1 alpha, 13, and to some extent, interferon-gamma were not detected due to their level below the background threshold. So we suggest that more sensitive diagnostic tools may be necessary to accurately measure the lower concentration of these cytokines in our samples. More so, the significant reduction that we have observed from this study with regards to IL-5, 10, and their ratio after treatment signifies a favorable therapeutic outcome. But we observe a better performance in IL-10, which suggests a potential mechanism of action following treatment and offers a valuable insight into the immune response against this infection. Our findings underscore the potential of these cytokines as an important biomarker for monitoring treatment response or showing a favorable treatment outcome. The significant reduction that we have observed in IL-10 levels in the control arm after 20 months may have been influenced by the general but significant decline in microfilarial loads as a natural occurrence of the body's ability to fight this infection. So our study has a limitation, and the limitation is that the levels of the cytokines in the patient samples were below the assay that we have used in this experiment. Even though we have done some optimization by increasing the sample volume, we did not observe any improvement. Further optimization, such as antibodies, incubation times, and conditions were not possible for us due to inadequate resources in our hands. So we have some recommendations. Based on the observations from our data, we are recommending a robust assay methodology that offers a high sensitivity capable of detecting lower concentrations in femtogram per ml in human plasma samples. We also recommend the usage of luminance assays, which offers relatively higher instrument sensitivities. Also, we recommend that assessment of cytokines should be evaluated at the clinical trial district to determine the true biomarker discriminating ability among onchocerciasis infected individuals. So funding of the study was obtained from UDCTP2. My acknowledgement and appreciation go to my supervisors and all those that were involved in this study. Thank you very much.
We can do it better for her. Thank you very much, Monica. To give us. Please, there is another section on the first floor. So if you are interested, you can join that section as well. There's another, there are power sections going on. We have one here. There are other sections on the first floor, so you can join them as well. Isaac Achampon will give us the next presentation.
All right, good morning. My name is Isaac, and then I'm presenting on difference in PPD and mitogen-induced T-cell activation expression for diagnosis and therapeutic monitoring of tuberculosis. This is one objective in my PhD work, and I'm being supervised by Prof. Lane and then Dr. Michael Frimpong. This is the outline of my presentation. Tuberculosis is a chronic disease. It affects about 1/4 of the global population, and about 5 to 10% of those who are infected with tuberculosis might develop the disease after an unspecified period of latency. Now, for the prevalence in Ghana, from hospital data, we have about 164 per 100,000 population. So you can see from the WHO graph that Ghana is among the endemic countries for tuberculosis. Now, during the treatment of tuberculosis, the treatment regimen takes about 6 months. And mostly after some time of treatment, it's difficult for patients to expectorate sputum. So that makes it very difficult for treatment monitoring. And therefore, of course, using sputum-based techniques. Therefore, the WHO recommends that other target profile products are developed, especially those that are non-sputum-based for the diagnosis of tuberculosis. And then they also recommend that other techniques that have been tried in different populations are validated in other populations so that we can see the best biomarkers for diagnosis. And several studies have been done, and they have proposed that blood-based biomarkers are actually very good for, potentially good for TB diagnosis. Therefore, our hypothesis was to use a blood-based biomarker that was based on response from stimulation by TB-specific proteins, specifically PPD, and then a mitogen called PHA. So we are looking at, our hypothesis was to look at how these are associated with treatment monitoring. The objective, therefore, was to look at the difference in Mycobacterium tuberculosis purified protein derivative and mitogen-induced expression of recent activation of T cells as a diagnostic and a treatment monitoring tool. The methodology, the study design, we used 2 study designs, a case control study and a longitudinal study. For the case control study, we recruited 60 new TB cases and then 37 controls. For the longitudinal study, we recruited 36 patients and who were followed up for a period of 6 months. For diagnosis of tuberculosis, the following were used: clinical presentation, chest X-ray, sputum smear and culture, as well as gene expect. The study sites were in the middle belt, somewhere here in Ghana, comprising Sena West, Asante Achim North, the Poo East, and then Atebubu Amantin district. Samples were collected, urine, stool, and blood. The urine, stool, and then the EDTA blood were used to exclude co-infections, whilst the sputum was used to diagnose the TB for using sputum ZN staining, sputum culture, and then gene expect. Then the immunological assay was done, specifically the TAM-TB assay with stimulations from PPD, ESAT, and then PHA. Also included a negative control. Now, during the assay process, the various stimulants were used. Then after that, we did intracellular staining as well as surface staining to be able to phenotype the T cells. the phenotype cells were acquired using flow cytometry. This diagram here depicts the gating strategy that was used. Of course, we used compensation beads and then also FMOs to be able to get out the respective expressions of T cells. At the end of the day, we were interested in two phenotypes, specifically interferon gamma producing T cells and then T cells with recent activation, that is CD38 positive T cells. Now the results. First of all, the results show that for cells without recent activation, for stimulations with PPD, ESAT6, and then PHA, only the mitogen show differences between TB cases and then controls. And then what we saw was that controls had a higher response, interferon gamma T cell response, than cases. And this has been seen elsewhere by Adankwa et al. 2019. What we are seeing is a hypo response to stimulation, and that characterizes the immunopathology in tuberculosis. Then we went ahead to look at the activation marker, the marker of recent activation, which is CD38, and then we observed that both the purified protein derivative as well as the mitogen all showed changes. And interestingly, for tuberculosis patients, we observed a higher response to PPD than the controls. Bear in mind here that our controls that we used for our study were adult contacts. These were contacts of TB patients staying in the same household. Further, to be able to establish that these are potentially latently infected TB patients, we made sure that these had higher responses to PPD. PPD is the protein that is used for the tuberculin skin test. So a high response meant that these people are latently infected. And so we observed that compared to active TB and then latent TB, the PPD response was higher in the active TB patients than the latent TB patient. This highlights the fact that TB patients are expected to have some hyperinflammation, whilst with response to PHA, it highlights that they have hyperresponsiveness. So this has already been observed by Potvin et al. 2014. But the difference here is that for Potvin's work, he used a mycobacterium pool of proteins comprising not only ESAT, because ESAT is the commonest, the lighter is not coming. ESAT is the commonest protein that is used for stimulation assays. So he used ESAT and then TB 10.4. But for our study, we tried to use antigens that were specific. So we used PPD and then ESAT as separate pools. And then also, we observed that the discrimination between our cases and our controls for PPD was higher, an AUC of about 0.8. So as far as we are concerned, the similar differences that we observed with respect to the interferon gamma response to T cells describes the immunopathology that is associated with tuberculosis. And also the hyperresponsiveness has been observed as probably due to either DNA methylation effects or serum milieu effects. And this has been already shown by Dinado et al. Dinado et al. Found that for TB patients, they had higher DNA methylation compared to controls. Harling also highlighted the hyperresponsiveness that was observed in TB patients. Now, utilizing these two effects, the hyperinflammation and then the hyperresponsiveness, which is classical for the TB patients we observed, we tried to use that to serve as a biomarker for diagnosing the tuberculosis. And so we found a PPD-PHA ratio. And when we use that ratio to discriminate between TB patients and controls at diagnosis, we observed that it improved the discrimination. Initially, it was just a little over 0.8, now almost 0.9. So using those ratios, it gives a higher discrimination for TB as against controls, and so it can be optimized as a diagnostic marker. Now, to also look at the response during treatment, mostly if you're doing a treatment study, it's important that you have a midpoint and then an endpoint. So we use the 3 timelines, and then we observe that if we only stick to PPD, you'd see that from baseline till 16 weeks, by 16 weeks, they go below the normalization level. So PPD response normalizes after 16 weeks with response to PPD. Now, for ESAT, which was used by Pottevin and then also used by HAZA in their protein pool, we didn't find such a response in our population. And of course, HAZA's work was done in Tanzania, and for their work, I mean, the population dynamics are a bit different from our population. And then we were specific to be able to tease out those who were properly latently infected as against our cases. Then for the PHA response, we observed that although we saw a change, an increasing change in the response, by the 16th week, there was no normalization. But when we combined the PPD and the PHA as a ratio, right from baseline through the 6th week to 16th week of treatment, we saw normalization. That meant that this PPD-PHA ratio could be used as a good treatment monitoring tool if we're able to optimize this assay. So in conclusion, we concluded that the difference in the PPD and mitogen-induced markers of recent T-cell activation can improve TB classification and then can be used for therapeutic monitoring. We published this paper in the Journal of Clinical Microbiology and Infectious Diseases. So based on the results, these were the limitations of the study. First of all, our samples were taken from just the middle belt of the country, so it may not be reflective if we want to include other southern and then northern sectors. Then also the sample size, the sample size for better validation and then optimization, a higher sample size would be used. But of course, based on the findings that we have, we can recommend that this response between PPD and PHA can be used for diagnosis and treatment monitoring. This work was done with support from the German Research Foundation. It was also carried out in KCCR with support from my PI, Professor Odame Phillips, and then our German collaborator, Professor Mark Jacobson. These are my references. Thank you very much.
Thank you very much, Mr. Champong. Shall we give him another round of applause for his insightful presentation? To give us our 4th presentation is Minazi Defree.
The senior faculty members, ladies and gentlemen, I'm very glad to be in your midst this afternoon to present my current work. This work actually is part or has set the platform for my PhD thesis, which I'm actually working on. So we are looking at the immune response against tuberculosis and non-tuberculous mycobacterial pulmonary disease in Ghanaian populace. As part of this work, we are going to look at a brief introduction and also consider the justification, that is the problem behind this work, and also give the methods that we use to achieve these results. And finally, we are going to give the results and then some recommendations that we need to look at for. So tuberculosis is a Mycobacterium disease that is well known. In fact, we are saying pulmonary disease, and pulmonary disease are diseases that are actually confined to the lungs. So in a layman, pulmonary disease are disease of the lungs. And we are saying that tuberculosis is caused by mycobacterium tuberculosis. And mostly this is the lungs, and these are the mycobacteria that are located. Recently, we have also come in line with one of the major problems that is also leading to pulmonary disease, that is non-tuberculous mycobacteria. And these are also caused by non-tuberculous mycobacteria, and they are known for infection in immunocompromised individuals, that is individuals with low immune system. But then recent publications and studies are revealing that even though individuals are immunocompetent, yet there are chances of they also suffering from non-tuberculous mycobacteria that leads to tuberculosis. So we are dealing with presumptive tuberculosis patients. As part of my work, these were individuals that were suggestive of tuberculosis. In the hospital settings, most of the people who present with clinical symptoms of tuberculosis are assumed to be tuberculosis patients. And most of the times, the common diagnostic tool that is used is a gene expert and then sputum smear and culture. But it's very unfortunate that during the course of diagnosis, the gene expert tends to be negative for the those that are non-tuberculous mycobacteria. So in terms for us to achieve what we want to get, we actually assemble presumptive TB patients in the clinical settings to look out for what we are looking for. So there's the need to understand the immunopathology of this infection to better understand the diagnosis and also the choice of the regimen of treatment that needs to be applied to the patient. So this is a brief immunopathology of the tuberculosis. And so as the individual get exposure, there are chances of you clearing the system when you have a strong immune response by the help of the T cells and the macrophages. This actually engulf or phagocytize these microorganisms, and by the help of activation from TNF-alpha, interferon gamma, they are able to clear it. And there are also chances that some of them will be a long time, that is about 9% of them will be in a long-term infection, and some actually due to decreased immune response or immune system will be an activation into an active infection. So we are saying that generally we have three main phases. There's a possibility that when you have an infection or exposure, you might recover safe, or there is an activity that will lead to latency, or you have an active infection. So what is the problem? We are saying that the diagnosis is very important. Like I said, in the hospital settings, gene expert has become the more or the commonest use in the deprived areas, and most of the NTMs are gene expert negative. So in this case, clinicians will tend, some of them will take the decision that this is the clinical symptoms and the radiography results is showing or depicting TB. They go ahead to treat TB. Others will also say that, okay, then let's look at other pneumonic infection. So they end up treating patients that actually are non-tuberculous mycobacteria patients. And then at the end of the day, we know that these organisms or the non-tuberculous mycobacteria are resistant to most of the first line of treatment for tuberculosis. That is the rifampicin, azithromycin, and the rest. And so therefore, there's the need for us to diagnose and probably get the right diagnosis for the treatment of the patient. So this complication determining of bacteria in the sputum or the smear, there's also lack of immune-based acids. Already we have interferon gamma release acid, the IGRA for TB, which mostly are applied in some developed countries and even here in Ghana. But then this is not available for NTMs. So there's the need to further go into this. Like I said, differentiation is very key for treatment regimen. So there's a study that has already been done which shows some form of abnormalities, that is reduced interleukin 7 receptor alpha, that is CD127, and interleukin 7 sensitivity. This is a short diagram indicating. The reality is that the ligation of this, that is interleukin 7 and its receptor, that is CD127, is very important because this will result into an appropriate signal that leads to cell differentiation, proliferation, and survival of the cells. And that will lead or protect the individual against the specific infection. We have also carried out an experiment or this study, which have already been published, and we have also identified CD27 as a pathognomonic feature of tuberculosis. That is, With or without stimulations, once you see reduced CD27, there's a possibility that that individual has TB. So coupled with this, we have also realized that if this has been done in TB, why don't you also see if you can replicate this among the NTMs? So our main aim is to investigate the role of these candidate biomarkers in immune response against the tuberculosis and non-tuberculous mycobacteria patients in Ghana. So the methodology is a prospective case control study. And of course, these are the sites we look at: Agogo, Sene, Yeji, and Atebubu. And these are the criteria. So these are presumptive tuberculosis patients, people presenting with clinical symptoms of TB. So we accept all these patients. So those with gene negative, gene express negative and positive, we recruit these patients, and then you go ahead to do the lab analysis. So for the cases, that is the presumptive TB patient, we had 169, and the control, and then you have 104, and then their contact, those living with the same jurisdiction or household, were 169. So the samples were taken, that is sputum sample, blood, and then questionnaire were taken. Then the samples were shipped to KCCR for laboratory analysis. So we did tuberculosis for bacteriology and then immunology. So for the immunological aspect, we did whole blood phenotyping for CD3, CD4, CD8, the CD27, which is a co-stimulatory receptor, and then we added the dye for cell viability, that is E780, and then the interleukin 7 receptor, CD127. The data was acquired using Beckman-Coulter, and then we also used part of this blood for PBMC isolation, and we used by density gradient centrifugation. The blood were mixed with PBS, layer on the fecal, spin, and then we have our layer, isolate the PBMCs. And these PBMCs were used for stimulations with on-stim depicting those without any antigen, the peripheral protein derivative, that's the PPD from the TB, and then the PHA for a positive control, that is the mitogen. And the data were under intercellular. When we stained, because we are looking for intracellular cytokines, we have bifidin A, which is a protein transport inhibitor, to ensure that the cytokines are kept within the cells, and after 16 to 18 hours, we do intracellular staining for this activity, that is interferon gamma expression. And part of the sputum were used for microscopy, that is acid bacillus staining, and then portion were used for culture using the Meiji tube, and then after culture, we do the TB test to ensure that we have TB control complexes or those that are not TB control. So we use the TB complex identification test. Those that were positive were considered tuberculosis, and those that were negative, we move ahead to do the line pro assay PCR to identify them as NTMs. So these are the gating strategies that I use to look for single cells, the lymphocyte, the live cells, and then I gauge on the specific cells of interest. So the FlowJo, as was the software used, we exported the data after FlowJo analysis into Excel. We rearranged them into graph parallelism, and then we use Mann-Whitney test to detect the differences within the groups, and also we do the rest as. So in summary, for the characteristics, we realized that out of the 104 samples that we took from the presumptive tuberculosis patients, 14 of them were non-tuberculous mycobacteria. So in this case, if you are part of this 14 patients that the doctor or the clinician is treating you for TB, there's likelihood that you take more than a year and you still not recover. And then we move ahead to look at our analysis. For the first analysis, we realized that the M tuberculosis PPD, that is peripheral protein derivatives for T cells, show higher proportions of interferon gamma CD4 positive T cells. So this is it. So you realize that, so for those at the back, the first one, the red line, it's gone again. The red line is for the TB. The middle one, that is the pink one, or the purple, those are good in colors, is for the non-tuberculous mycobacteria, and the blue or black one depicting the contact, that is the controls. So you realize that there's high level of interferon gamma CD4 T cells in the TB patients in comparison to the non-tuberculous and then the contact. And this is true because, of course, what we are using here is the peripheral protein derivative, which is part of the immunogenic proteins for tuberculosis. And these are absent in the NTMs. So obviously, we are seeing that even though the clinical symptoms of these presumptive TB patients were the same, in terms of immunologically, we realize that they are different. And for the second one, we use the PHA, which is a positive control, and also we realize that there's a decreased activity in the TB patient as compared to the NTMs and the controls. So this is also very true, as the previous presenter rightly said. Once you have TB, it is a immunopathology that there's a reduce in your immune response, and therefore you are not able to stimulate the necessary response that are needed for fighting against this infection. So we also move ahead to look at the CD38, which is activation marker for T cells. So we also realize that when you compare the TB patients to the non-tuberculous mycobacteria patient and the contact, we observe significantly higher CD38 positive PPD specific T cells in tuberculosis patients than the healthy contact. And over here, you can also clear that for the NTMs, they were a bit reduced, even though the data was not significant, but you can clearly see that there were differences. And finally, we went ahead to do the ex vivo phenotyping for the markers that were used to differentiate between adult contact and TB patients. Like I said, we first published a paper on the ability of this CD127 to differentiate between TB patients and adult contact. So we want to replicate this if it's possible. And also the pathognomonic effect of CD27, we also did the ex vivo phenotyping to see this. And you will see over here that like we observed, there's a reduced level of CD8 positive CD27 expression in TB patients as compared to the adult contact. So there's clear differences that even though the NTMs and then the TB looks the same, yet there's a clear difference between the contact and then the cases. And again, this was also seen for interleukin-7 receptor alpha. So this confirms that the previous studies that actually depicted or discovered that there's a reduced activity of interleukin-7 and its receptor CD127 has been reconfirmed over here. Even though when you compare the NTMs and the TB, they are not actually significant in terms of their expressions. So finally, we will say that our result showed that NTM pulmonary disease resembles tuberculosis clinically. That is, when you look at a patient, when a patient presents to the hospital, there's a likelihood that you identify or you presume this patient are TB patients. That is for clinically. But immunologically, our results have showed that these patients are different and they needed to be treated differently. And again, we have seen an abnormal expression of interferon gamma CD38 activated cells, and then CD27 and interleukin-7 receptor alpha activity to be abnormal in TB and then the non-tuberculous, but then they were normal in the adult contact. And that shows that even though these are also similar, yet further studies need to be done. So in general, what I'm saying is that my recommendation is there's the need or the urgent need for further studies to understand the immune mechanisms of these NTMs, and that will aid in its diagnosis, because we realize that if out of 104 patients are taken and 14 of them are receiving the wrong medication, then it's called for, it's not very alarming. There's something that needs to be done about it. So therefore, there's the need to urgently look out for these biomarkers that could be able to use to differentiate the NTMs from the TB patient. And that is forming the basis of my PhD thesis. So these are my references, and I'd like to acknowledge my supervisors and the MAPTB team from KCCR, and the KCCR for giving us the opportunity, the Ghana Health Service for the patient, and then also the platform giving me to share this pilot studies that has already been published. Thank you very much.
Thank you very much, Mr. Diffrey. Shall we do it better for him? A lot goes into immunological studies. I mean, he's done very well. Our next presenter is Paul Intiamwa. Shall we welcome him with a round of applause, please?
Good afternoon. I'm Paul Intiamwa, and I present on interleukin 6, tumor necrosis factor alpha, and NLP3 inflammasome as potential biomarkers for physical frailty in people living with and without HIV infection. We are going to go through a brief background through to conclusions and recommendations. Okay. People around the world are living longer due to advancement in medicine, improved sanitation, and nutrition. And persons living with HIV are also living longer due to improved access to effective antiretroviral therapy. The UN sees this increases in life expectancy as one of the greatest achievements of the human race. However, aging is often associated with chronic comorbidities and physical frailty, which eventually results in death. Inflammation plays a very important role in the cause of HIV infection, as well as in the development of frailty, disease, and in the aging process. And some of the important inflammatory markers include NLP3 inflammasome, TNF-alpha, and interleukin 6. Assessing the levels of frailty in the elderly is complex, requires several measurements, and this makes research in this area and clinical diagnosis quite difficult. So this study sought to identify the levels of physical frailty among the elderly and also investigate the interleukin 6, TNF-alpha, and tumor necrosis, interleukin 6, TNF-alpha, and NLP3 inflammasome as potential markers for physical frailty among the elderly. We conducted this study at St. Elizabeth Hospital, Hwidim, and Holy Family Hospital, Techiman. After we obtained ethical approval, we sought informed consent from potential clients at the ALT and then OPD. And those who 77 ALT clients were enrolled, as well as 104 confirmed HIV negative persons were also enrolled. We use frailty phenotype to categorize our participants into frail, pre-frail, and non-frail, whilst we use a standardized questionnaire for demographic information. We collected blood, whole blood into EDTA and used the plasma to analyze, determine the plasma level of interleukin 6, TNF-alpha, and NLP3 using sandwich ELISA techniques. Data was analyzed with Stata, and we did univariate ANOVA, comparing the markers with physical frailty. And then we put these markers also into a multivariate analysis. And p-value less than 0.05 was identified as being significant. Our participants were majority female, and the number of participants also reduced with increasing age, likely depicting the life expectancy in Ghana. We obtained frailty prevalence of 15.5%. That's overall frailty prevalence 15.5% in our participants. And this fell within the range obtained by Collard et al., which was 4 to 17%. However, some studies had lower prevalence, others had higher prevalence. And the differences between ours and this study might have arisen from the difference in the operational definition of some of the frailty components that we measured. We also have differences in age ranges, and then the geographical location of some of these studies also impacted, resulting in the differences. We also had higher prevalence of physical frailty in HIV clients as compared to the HIV negative clients, 19.5 versus 12.5%. And many other studies have also had similar results. However, Edwards et al. In 2020 had comparable results between the two. A combination of some physiological and immunological changes, which is common to both the aging process and HIV infection, influences the development of frailty among HIV-infected persons, and multiple pathways relating to the direct and indirect effect of HIV also accounts for the higher prevalence of HIV, frailty in HIV participants as compared to the HIV negative participants. With the markers, univariate analysis obtained significant association between frailty status and all the markers. TNF-alpha interleukin 6 are two of the most widely studied markers with cytokines as markers of physical frailty. So we have many studies having similar results as ours. However, Tay et al. And Ranosova et al. Had observed no significant difference between the frailty status and the markers. The aging is associated with reduction in testosterone and then estrogen. There's also genetic variation as well as the presence of disease, and this influences the persistent high levels of these markers within the elderly. And persistent high levels also in turn leads to more diseases in the elderly. With TNF-alpha, with inflammasome activation, when there's an assembly of inflammasomes, what happens is that there's a cascade of events is unleashed, and that results in the interleukin-1, active interleukin-1, and then interleukin-18, with subsequent pro-inflammatory effects. We have not come across studies comparing inflammasome activation or trying to identify inflammasome as marker of physical frailty. However, we've come across studies where interleukin-18 gene expression has been related to physical frailty, and salivary levels of interleukin-1 beta has also been related to physical frailty. When we put these markers in a unit, when we stratify by their HIV status, we realize that all the markers still remain statistically significant. But when we put them in multivariate analysis, we realize that only the inflammasome activation was significantly associated with frailty status. And this is because inflammasome is activated by a wide range of stimulants, and frailty is about accumulation of deficit. So inflammasome activation is likely to pick more deficits than the other cytokines. So in conclusion, this study has obtained higher prevalence of frailty in HIV positive clients as compared to HIV negative clients. And then we have also identified NLP3 inflammasome as potential biomarker for physical frailty that needs to be further explored. We recommend that geriatric centers be set in our hospitals and physical frailty assessments should be made routine for all persons who are 60 years and above. And we also recommend further studies using larger sample size to analyze the relationship between NRP3, inflammasome, and physical frailty. I acknowledge my supervisors in a special way, the participants of the study sites, as well as the staff of the study sites, and all those who help this research to be successful. Thank you.
Thank you very much, Mr. Imtiamwa. Please have a seat. Please don't forget to note down your questions. Right after the last presentation, we'll go for the Q&A section. Veronica will give us the last presentation. Shall we welcome her with a round of applause, please?
Good afternoon, honorable chairpersons, all protocols duly observed. My name is Veronica Ajiwan, a PhD student in hematology. My supervisors are Prof. Ochiriadae Mensah, Dr. Enoch Odameyanto, and Dr. Kwekupoku Asante of Kintampo Health Research Center. I must mention that this is still work in progress, and so I may not show you much of data that has been analyzed. Hopefully next year I'll be here, God willing, to share with you very interesting results from my study. So I'm looking at lead exposure and anemia in pregnancy. What's the contribution of delta aminolevulinic acid dehydratase polymorphisms play on blood lead levels, both in peripheral blood and also on cord blood, and how these are affecting the predominant cases of anemia and adverse birth outcomes in the middle belt of Ghana. This will be the outline of my presentation. So anemia affects more than 600 million people worldwide. That is women within the reproductive age group. In Ghana, it is estimated that more than 70% of pregnant women are anemic. Lead exposure is a major public health concern worldwide. In fact, lead is considered as one of the top 10 substances of considerable public health importance that requires all the needed attention to eliminate it. But lead exposure represents one of the neglected causes of anemia within the population. It is very understudied when it comes to anemia etiology. Lead exposure is associated with several adverse outcomes for both the mother and the infant. Some of them include stillbirth, premature delivery, spontaneous abortions. Talk about all the adverse birth outcomes. You can find lead exposure playing a role over there. The toxic effects of lead affect almost every organ system in the body. As you can see here, this picture from WHO. But how do we get lead into our bodies? We can inhale lead from lead particles and fumes from the environment due to the activities of smelters, factories, and all that. So you can inhale it. You can also get it into your body by eating it. So the food that we eat, where it is grown, the plants, vegetables, they can all absorb lead from the soil. And when we eat them, we get exposed to lead. Lead can also penetrate your skin. So when you come into contact with objects that are contaminated with lead, it will penetrate your skin. And then there are also endogenous sources of lead exposure. And that is where the problem lies when it comes to lead exposure in pregnancy. I'll talk more about that in my next slide. So these are some of the examples of the activities that we do that will expose us to lead. So leaded pipes in our homes, we don't know whether they contain lead or not, we do not know. Some hobbies that we do, these ceramic bowls that we eat from, plastics and all that, some of them are glazed with lead, and as we come into contact with them, we get exposed to lead. So the endogenous sources of lead is when there's increased bone turnover, when the body needs a lot of calcium to come back into circulation during pregnancy and lactation, and also aging and menopause. And those ones will cause lead to be recirculated from the bone into circulation, and this can affect the developing fetus. So lead inhibits one of the main enzymes involved in the production of red blood cells, heme for the production of hemoglobin in the body. And that enzyme is the delta aminolevulinic acid dehydratase that is required in the second stage of the heme biosynthesis. This enzyme also has two codominant alleles, and that's ALAD1 and 2. And evidence suggests that individuals who inherit the ALAD2 gene exhibit higher levels of lead because that polymorphism has a lot of affinity to absorb a lot of lead. We, however, do not have much data on how these are all playing roles in the predominant cases of anemia that we have within the population. Why do we want to carry out this study? Lead is everywhere. We come into contact with it every day, but it doesn't degrade. Once it gets wherever it is, it will stay there until you remove it. And your constant engagement with that object will lead to continual exposure. Sorry. When it gets into your system, within 40 days, it will be within the blood system. It will be in your blood. Then after 40 days, it will move into storage in the bones and also soft tissues. And then the kidneys and the brain, where it causes all manner of neurological problems and renal problems. Then during pregnancy, as I mentioned earlier, the body will need a lot of calcium. And so there's mobilization of calcium from the bones, and lead that is stored there will come into circulation. And once it gets stored in the bone, it will be there for several years, decades it will be there. Then the problem too is that when lead comes into circulation, it's able to cross the placenta barrier and affect the developing fetus. And dividing and immature cells also have very high affinity for lead. Unfortunately, the detrimental effects of lead exposure are more pronounced in developing fetuses, pregnant women, and young children. There's no level of lead that is considered safe. But we all have some amount of lead in our system, but no level is safe. I would even want to ask, who has ever checked his or her lead level before? We don't check, we don't investigate it, but it is there. However, the CDC recommends that a level of 3 micrograms per deciliter and above should be considered as the level of concern that will require immediate public health intervention. Initially, it used to be 10. They reduced it, I'm saying we, as if I'm part of it, but CDC reduced it from 10 to 5, and still we were recording several adverse health effects even at the 5. So we realized that the 5 is still high and has recently been reduced to 3. Unfortunately, the detrimental effects of lead, as I said earlier, more pronounced in children and pregnant women. But we do not have any data I haven't come across on how lead is influencing the predominant cases of anemia that we have within the community. So we aim to determine the association of lead levels and how the effects of allied polymorphisms are all playing roles in the predominant cases of anemia that we have in pregnant women in the middle belt of Ghana. So first of all, we are determining trimester-specific lead levels and then see how hemoglobin levels are also coming out during each trimester and how these are associated. We are also collecting cord blood samples at birth to measure the levels of lead and to see how these are influencing birth outcomes. And we want to determine the level of influence of allied polymorphisms on blood lead levels and anemia as a whole. We've realized that a lot of us don't even know about lead exposure, so we want to collect information about the level of awareness of pregnant women on lead exposure as well. So this is a prospective cohort study. It's being carried out at the Kintampo Health Research Center on a study that is currently ongoing called the PRISMA study. This study seeks to document adverse birth outcomes in pregnancy. So the inclusion criteria will be pregnant women in the PRISMA study who are less than 14 weeks gestation and willing to provide informed consent. And those who are above 14 weeks gestation and less than 18 years will be excluded from the study. And we are seeking to recruit 300 participants into the study. So this is map of the study area, the Kintampo North Municipality and South Districts. So once consent is provided for pregnant women who are less than 14 weeks, we collect background information. And the time points where we intend to collect, we are still collecting the data. First trimester, less than 14 weeks, and then 20 weeks gestation for second trimester, and 32 weeks gestation for the third trimester. We are doing it this way because we want it to align with the study time point so that we don't overburden the mothers with frequent blood draws. Then at delivery, we'll collect cord blood samples and then follow them up within the 28 days after delivery to document adverse birth outcomes. We are measuring full blood counts at every trimester. We are performing blood film comments by Leishman staining. Filter blots are being prepared for allied polymorphisms by restriction fragment length polymorphisms. And we are also doing ion studies by the Quansis multiplex, and also parts of the ion studies will be done by using Pentra C200, specifically TIBC. We have obtained ethical approval from KNUST, from Kintampo Health Research Center, and the parent study has also received ethical approval from Ghana Health Service. Mothers are signing informed consent. We have sought permission from the various facilities where we are conducting the study. We are also doing a lot of community engagement because most of us do not even understand why we are collecting a lot of blood. So that is being done at Kintampo Health Research Center. We also organize frequent stakeholder engagements to sensitize stakeholders on the importance of the studies that we are carrying out. So we expect that at the end of the day, we'll be able to provide some baseline data on blood lead levels among pregnant women in the Middle Belt of Ghana. We'll be able to determine the association between anemia and allied polymorphisms, and also determine the level of awareness of pregnant women on blood lead levels. And we hope that at the end of this study, we'll be able to provide some baseline data on which some bigger interventional studies may be conducted to understand how lead exposure is influencing anemia and birth outcomes within the Ghanaian population. So all 300 participants at first trimester have been enrolled. We determined the gestational age by ultrasound. We have performed FBC at enrollment for all the participants. We are doing the follow-up visits. So at each follow-up visit, we do the FBC. We are going on with the ion profile analysis on the Quansis platform and on the Pentra platform. We are, however, still in talks with Ghana Standard Authority for the lead analysis, and hopefully in the coming days, we'll be able to ship some of the samples that we have stored so far for analysis. Next steps, we hope to complete the lead analysis as mentioned, perform the allied polymorphisms, and do data analysis. I'm so grateful to my supervisors, Kintampo Health Research Center, the PRISMA study team, Ghana Standard Authority, my study participants. and my colleagues. Thank you very much.
Thank you very much, Veronica. Okay, it's time to take our questions. I'd like to invite all our presenters upstage. Jacob, Monica, Isaac, Minazi, Paul, and Veronica. Okay, we start with our questions. Please show by hands if you have any questions. So, for fairness, we take 2 here, 2 here. They answer, then we move on. I saw a hand here.
All right, thank you. My question goes to the man who worked on the non-tuberculous mycobacterium. I want to know what happened to the 14 participants after you detected that they were not having the normal tuberculosis, and then what treatment options are available for them?
Thank you for the question.
Thank you very much. My question is on the first presenter, on Jacob. If you can put the slides back. The gentleman that presented on the colorectal cancer, there's something that I wanted to be clear, which is with respect to the methodology, I just wanted to be clear on something. So I want to know how he recruited the colorectal cancer patient. Then whether he used the tumor or the peripheral blood, which is which. You made mention about the tumor microenvironment. Did you use both the tumors and the blood to look at the expression of the T cells, or just the blood? And with recruitment of the colorectal cancer patients, there was no slide on their social demographics. I don't know whether they were on any treatment regimens, chemo or radio, because T cell exhaustion can come in when they are on these medications. I'm also working on colorectal, so please, if I can get time to learn a little bit about what you presented. So, Prof, if you can go back to the next slide for me. Okay. So something on the social demographics, I just want to know how you recruited the patient and if you really compare the expression of these T cells in both the tumor microenvironment and within the peripheral blood.
Okay, thank you.
Right, thank you very much for your question. If I read, you were asking what happened to the 14 participants who were diagnosed as NTNs based on our project. Yes, so like I said, these were individuals who were recruited into the system as TB patients. So as part of these studies, we wanted to better understand. So obviously these patients, I can't relate it because we did not follow the patient. There's a probability that they might be given TB medications, or they might be looking out for, the clinicians might be looking out for other pulmonary disease. So I can't really tell what really happened to them. But there's a possibility that the clinician will take them as TB patients and continue to treat them with the TB regimen, or they might be considering other forms of pulmonary disease. Thank you.
Okay, thank you very much. So I think I noticed that I've left out my table 1, which contains the socio-demographic parameters. So these were patients that are clinically confirmed that they are colorectal cancer patients. And the samples that I worked on are peripheral blood. That's what I was talking about. I was saying that the peripheral blood expression levels of T cells are not perturbed in colorectal cancer. And then the hypothesis or my recommendations were that instead of looking at the peripheral blood, we should rather look at the tumor cells themselves, the microenvironment of the tumor cells.
Were they preoperative or post the patient?
So these are newly diagnosed cases.
So no surgery?
No.
Chemo?
Pardon?
Were they on any treatment? Like?
No, I'm saying newly diagnosed cases.
Okay.
So they were undergoing colonoscopy and also for surgery, but the samples were taken before the surgery.
Okay, thank you very much. And the presentation on the frailty, is there a gold standard for diagnosing of frailty? What was from your presentation, I saw you have there was some classification, if you can throw some more light. Then, with respect to your patient, did you really check for autoimmunity, like rheumatoid arthritis, because the expression of these cells might also affect these levels?
Yeah, please, my question goes to the lady who presented on anemia and pregnant women. I want to know why you decided to do your work in Kintampo. And also, how are you going to categorize your cases in terms of anemia, the values that you get? And did you take into consideration the jobs that these women do, and also other compounds that could affect the enzymes?
Thank you for the questions. Yes, frailty. We use the freeze frailty 2. That's the most commonly used frailty 2. There are a number of them, frailty index, and some of them measures up to 66 parameters. So this was a 5-component parameter, and we measured exhaustion. That was a simple question. Yeah, an answer to yes. Did you feel tired for no reason within the past 3 months? Yes. If you answer yes, then you have a deficit. So we score you 1. It's a 5-point scale. If we also measured weakness, and we use hand grip strength, so we use hand dynamometer. They applied force to the dynamometer. We measured the strength, the pressure that they applied on it. And this was stratified by gender and age. And there's predetermined reference ranges. So with that one, we will score you 1 if your grip strength is abnormal. We measured shrinking, which is unintentional weight loss, BMI of less than 18.5%. So if you fell into this category, we gave you a score of 1. We did the same for energy. We gave them pedometers for 1 week and retrieved the pedometers. And stratified by gender, those who fell below the lowest quintile were given a score of 1. And the next one was also slowness. So 6 meter speed gait. They walked for 6 meters. We had made marks at 2, 8, and then 10 meter mark. They started from 0. When they got to the first leg cross, the first line at 2, we started timing. And then the first leg crosses the 8 meter mark, we stopped the timing. That one to stratify by height and gender, those who fell below the lowest quintile were given a score of 1. So those who scored 0 out of the 5 were classified as robust or non-frail. Those who scored 1 or 2 were classified as pre-frail, and those who scored more than 2 were classified as frail. And that's the categorization that we did. We did not do anything on autoimmunity or cytomegalovirus. All these ones would have been limitations of our study. Thank you.
Thank you very much for your question. So I chose the Kintampo Health Research Center because I mentioned that I'm leveraging on a currently ongoing study called the PRISMA study. As part of the PRISMA study, we are also looking at anemia in pregnancy. The WHO recently released new guidelines on determination of anemia in pregnant women. And for first trimester participants, it's less than 11 grams per deciliter. And for second trimester, it's 10.5 grams per deciliter and below. And for third trimester, will be 11. So that is the categorization that I will use to determine the anemia in the pregnant women. In addition to that, I am not looking at other compounds. These compounds are very expensive to measure. I really wanted to add arsenic and mercury as well, but they are very expensive, extremely expensive. And per my sample size, I'm looking at 1,200 samples. And each one of them costs not less than 200 cedis per test. So you can imagine if I should add the other metals, it will be extremely expensive, considering other aspects of the study that will also need financial support. Thank you very much.
Thank you very much. Any more questions, please?
All right, so this morning we've been discussing collaborative research. And we all know how difficult it is to take TB medications. You take it for a very long time. And if you have 14 people taking medications that we all know will not benefit them, I think you have to follow up this for us. Then you give us the feedback.
Thank you. I think it's a recommendation, right? Yeah. Yes. Sorry.
Thank you so much. I have a simple question to, is it Diffrey? Yes, so maybe the answer to your question may warrant another question or explanation. When you say non-tuberculous mycobacteria, can you list them for me? I just want, on the basis of that, I may ask another question. Yes, which are they? Because of where I come from, that is why I'm saying so.
All right, thank you very much. So as part of your recommendation, and that is why this formed part of my PhD thesis. So it's the initial work was what we built on to get the grant for my PhD. So obviously, we want to follow up on them. So the current work is going to be a follow-up studies to also ensure that the patients get the right benefit from it. And okay, the second question, you said I should list.
Just list them. I want to
okay,
list,
so
yes.
We have two groups. You have the fast growing and the slow growing.
So just mention them.
You have the M42, which currently is most common within our jurisdiction.
Okay,
you have the M. cancini, you have the abscessus and the rest. Okay. So there are lots of them that we deal with.
So now let me come on with something else, and maybe we can help each other.
Okay.
We also have TB in animals. We have M. tuberculosis, which you have. We have M. bovis, and we have M. avis. And we know that if you take milk unpasteurized from a cow with TB, definitely you come down with TB.
Yes.
So that was what I wanted to find out. If you say non-tuberculous, are you referring only to M. tuberculosis, or all these are covered? That was just why I was looking at that. I don't know whether you are getting where I'm coming from.
Yeah, I'm getting where you are coming from. So we classify all of them as non-tuberculous. So as part of this work, we did not classify them, but as part of my PhD thesis, we are classifying all of them. And so every NTB that we isolate, we classify them to look at which of them it is. So for this particular work, we did not do the classification as in whether it's M42 or it's from other form of NTB from maybe animal source or whatever. But as part of my thesis, we are working on to classify all of them based on the isolate that we get.
Thank you. Thank you very much. We take last two questions.
Thank you very much. Diffrey, Yes, with respect to the staining, I saw that you use whole blood and PBMCs. And with the stimulation of the mitogens, you use the PBMCs. Is it possible to use the whole blood for that process too? And why did you choose to use the PBMCs?
Yes, it's possible. And as part of our TB work, we use whole blood for the TAM assay. But for this particular way, we needed to replicate what has already been done, and it was done on PBMCs. So it forms part of, the basis from which we are replicating or doing additional works. So even though the initial one was done on PBMCs, we compare and contrast and realize that the same thing can be replicated using whole blood. So both of them is fine. But the initial one was done on PBMCs. Thank you.
Okay, thank you. Any more questions, please?
Thank you very much. My question is to the two people presented on TB. I realized their study sites were a bit similar. Their research settings were a bit similar. So I was asking the reason behind that and what informed their decision to do the study there.
Do we have any other question?
All right, so our supervisors, in terms of projects at KCCR, we have the same PI and the same external collaborator. And my previous work was the basis for the findings that was used for his work. So we are still doing the work in those same communities where we found the NTMs from the previous study. That's why we have the same communities where we're actually working. Yeah.
So to add a little, the initial idea was for TB. Then from the TB work, we realized that NTMs. So that is why we are having the same common, path.
Okay, thank you. We have a question here.
My question goes to Isaac. In your study design, you have case control and then prospective observational study. Can you explain how you applied the two and how your cases and controls were selected? Thank you.
Okay. So for the case control study, we looked at TB cases that were diagnosed but hadn't begun treatment. And the controls were selected as household contacts of the TB patients. And then furthermore, to increase the chances that these patients were latently infected, we looked at their PPD response and selected those who had higher response to PPD as the contacts. Now for the longitudinal study, follow-up studies are very difficult. In fact, we began with a sample size of 169. By the time we excluded those with parasitic infections, those with other comorbidities, by the time we looked at those who had all the time points followed up till we had quite low numbers, and so we had to work with the lower numbers that we had. So that informed the sample size for the longitudinal study. But these cohorts are a subset of the TB cases that were used for the case control study design.
It's a follow-up question. Please take it.
So I want to find out if the cases and controls, they were the same people you used for the longitudinal phase. And then in terms of the selection of the controls, you said you did it at the household level. So I want to find out what if you selected a control which was actually a case, or what measures did you put in place to ensure that you did not select a case as a control? Thank you.
Okay, so for the longitudinal study, we did not use controls. We we just followed up TB cases that had been diagnosed, and then we're following the standard treatment. We're going according to their regimen. We're meeting all the timelines. We had no co-infections and all that. Now, for the controls that was used for the case control study, the controls were patients who were people who were asymptomatic. They were asymptomatic household contacts of the TB cases. So clinically, they had no TB. And then, of course, we checked for their responses, as I said, just to increase the chances that these are, although asymptomatic, they are likely latently infected tuberculosis patients. Yeah. Thank you.
Okay, thank you. Any more questions?
So I think I'll ask one question because Monica has not been asked any question. So Monica, I'm just looking at your one of your conclusions, which you are saying there's a reduction in IL-10, which you think is probably as the body's way of fighting the infection. So, in effect, do we still need treatment if the body can be able to fight the infection? Because you are saying the IL-10, there was reduced IL-10, but you're also saying there was insignificant decline. I don't know how to put the two, significant reduction and then insignificant decline. So how do you marry the two?
Thank you so much for the question. What I'm trying to say in that point is that I did not bring the results on the microfilarial load in the clinical trial that we did. So during the clinical trial, we realized a significant decline 20 months after follow-up in the arm 4, but we did not bring the results here. That's why I am saying that it could be as a result of the insignificant decline, even though there was a decline, but it was not significant. Yes. Yes, please.
Please, to the same presenter. For the treatment of onchocerciasis, normally we use ivermectin, but in your presentation, you use rifampicin and albendazole. I wanted to know your reason behind it.
Yes, so thank you so much for the question. As you have indicated, the MDA employs ivermectin for treatment of onchocerciasis, but the World Health Organization has a goal to eliminate this disease by 2030. So what are the procedures in attaining this goal? By looking for an alternative medication that can target the adult worm. Because the ivermectin only targets the microfilaria, it doesn't target the adult worm, and you have to administer this drug for a long period. So we are looking for a drug that can target the adult worm. So they have discovered that rifampicin, when combined with albendazole, is able to kill the adult worm in animal models. So we are doing a clinical trial using the high dose rifampicin combined with albendazole to be able to know whether it can kill the adult worm so that we can attain the World Health Organization goal of eliminating this disease by the year 2030. Thank you.
Any more questions, please?
Okay, so I think I'll ask another one again. Just one. I mean, this is my area, so sometimes you are looking at polymorphisms, and you are looking at it in relation to your blood lead levels. So you talked about ALAD1, ALAD2. So what is the fine relationship between the polymorphisms in terms of a normal person compared with maybe somebody, because I'm sure you are looking for some, polymorphisms that will predispose somebody to either getting increase in their lead levels or otherwise. So what is the mechanism behind that?
Thank you very much. So there's a GC transversion with the ALAD polymorphisms. So that causes the ALAD2 to be more electronegative. So with that, it's able to attract lead, which is electropositive. So individuals with the ALAD2 polymorphism absorb more lead due to this mechanism, and that makes them more susceptible to the toxic effects of lead. Thank you.
All right, so your work looks very interesting. Looking at the effect of lead on RBC synthesis, it doesn't only affect alpha amino levulinic acid, it also affects ferrochelatase. So the question is that if you're looking at polymorphism, why are you not looking at polymorphism for both ALA and then ferrochelatase? But you're only concentrating on only ALA. So what happens if somebody has a double polymorphism, one for ALA and then one for ferrochelatase?
Thank you for your question. So lead actually affects 3 main enzymes in the heme biosynthesis: ferrochelatase, coporphyrinogen synthetase, and alad dehydrogenase, delta amino levulinic acid dehydratase. And the alad is in the second stage of the heme biosynthesis. And that is where the effect of the polymorphism on lead exposure is more pronounced. So if you are talking in terms of percentages, its effect on the alad is about 90% compared to the others. So it is more important to look at that because of the magnitude of the effect it has on alad compared to the other enzymes. Thank you.
Thank you very much, our presenters. I guess this brings us to the end of the Q&A section. We'll give each one of them 30 seconds to give us something to take home.
Thank you very much. What I would say is that lead exposure is here with us. Don't say that it doesn't concern me. It concerns you, it concerns me. Because the vegetables that we are eating, we don't know where they are grown. The pure water you are drinking, you don't know where it's coming from, whether it's from leaded pipes or not. As you walk about, you don't know how much lead you are consuming into your body. I did a study in Ahafu area in Ghana, and painters had, all of them, 100% of them, had elevated blood lead levels. So the paints that we come into contact with, who is checking whether there's lead in it or not? We are all exposed. We also, everybody has some amount of lead, as I mentioned earlier, and there's no level of lead that is considered safe. Let's get tested. There are many cases of hypertension that we have in our community with strokes and all that. Have we checked lead? Because lead contributes to all these adverse outcomes. So today the take-home message is that as we go out, let's get tested for lead. Let's check our environment for lead exposure, and let's raise awareness for lead exposure. Thank you.
Thank you. You've given us more than 30 seconds.
Okay, thank you very much. So I would say that colorectal cancer is a very common cancer, but unfortunately less studied, or a type of cancer that less attention is given to it. And for that matter, more students who are interested in cancer research should look at colorectal cancer as well. And the literature suggests that when we are about 40 years and above, we are all at risk of getting colorectal cancer. But then in the clinics, I'm coming across patients who are even less than 30 years. And so it is important that once every 5 years, we go for routine screening, endoscopy, to just look at our rectum and colon to be sure that we are safe. Thank you.
Okay, so I just want to say that tuberculosis management, especially from the patient perspective, is very hectic. Taking drugs for 6 continued months is difficult. In addition, most of the first-line drugs, rifampicin, isoniazid, pyrazinamide, are hepatotoxic. So it is important that when patients get cured along the treatment line, they don't have to continue the treatment to the 6th month. And the best approach is to have a very good monitoring tool that can monitor recovery during treatment. And so from my study, further validation should be that in other populations so that we can fast track moving this from basic science to the clinical space for us to be able to monitor our patients effectively. Thank you very much.
Thank you, Isaac.
All right, thank you. So to add to the TB patients, in fact, like my brother said, it's very difficult taking the medications. So my attention to the clinicians is that it's very unfortunate that most of the available resources, that is the gene expert that is currently used as a basis for diagnosis of TB, actually exclude these NTM patients. Or based on suggestive clinical symptoms, doctors continue to treat them as TB. But there's the need to reconsider. So patients that are suggestive of NTM, tuberculosis are not always tuberculosis, but then there's a possibility of NTMs. And I hope that my research will bring in a more robust biomarker that would help in facilitating and discriminating the NTMs from tuberculosis to aid in patient treatment. Thank you.
Thank you, Minazi.
Thank you very much. I want to say that my study is very important in achieving the goal 3. That is attaining good health, and not only the goal 3, but 4 and 5. That is equity and then gender balance. So my study is very important in achieving these SDG goals. Thank you so much.
Thank you, Monica.
Thank you. What I will say is that let's take care of the elderly members of society more serious. One day, we'll all become old. We'll become the elderly, both in our health facilities and in the society. The extended family that provided social security for elderly person is waning. Are we ready to accept institutionalization where we'll be put in care homes when we are older? Let's try to influence policy now. Let's take care of the elderly serious wherever we find ourselves, whether in health facilities or in the society. Thank you.
Thank you, Paul, for your advice. It's a bit scary, though. Thank you. We draw down the curtain on this section. We break for lunch, and after lunch, we come back for the afternoon section. Thank you all for gracing this oral session. We meet again in the afternoon. Thank you.